Okay, good evening, everybody. Happy Wednesday, I think it is. Thanks so much for spending time with us this evening as we dive into this important discussion around men's health. You might not know this, but tonight's event is extra special because June is Men's Health Month. So while men's issues happen year round, we know that we like to take a special opportunity in June to just be more intentional about focusing on educating and treating men's health issues. So thanks for spending the next 45 or so minutes with us on this educational webinar and for prioritizing your own health. A couple reminders before we get started. First, this presentation is completely anonymous. You're not on camera and no one can see your name. And we do this because we really hope to have an interactive discussion. We want you to feel comfortable asking questions, even if you're afraid they might be embarrassing or you're not sure the right words to say. So to maintain your privacy, you can write your questions in our anonymous chat box at the lower portion of your screen, and we'll save time at the end of the presentation to answer as many as we can. So we have over 50 people in attendance tonight so far. And so just a reminder, if you have a question, somebody else probably has the same one, so don't be shy to ask. Our speaker tonight is Dr. Charles Kaplan, who you see there on your screen. He's a urologist and a men's health expert at Georgia Urology. Dr. Kaplan focuses his practice around helping men who are dealing with men's health issues like many of the men joining tonight's webinar. So he has a wealth of relevant information to share with us this evening. Dr. Kaplan, thanks for postponing your dinner and spending a few minutes with us. I'll kick it over to you to get us started.
All right. Thank you, Amanda. I'd like to thank everyone for attending this tonight and taking their time out of their evening to listen to an important men's health topic, erectile dysfunction. And I know it's a difficult topic for a lot of people to talk about, so I'm glad everyone attended. So we'll move ahead. So these are my office address. I have 3 addresses, just if you were interested. One's in Smyrna, Woodstock, and Douglasville. I've been in practice now with Georgia Urology for almost 25 years. I did my residency training at Georgetown University in Washington, D.C., and I specialize in men's health, specifically erectile dysfunction, is also in something called prosthetic urology, which is the treatment of not only erectile dysfunction, but incontinence in men and in women. So tonight we're going to talk about erectile dysfunction, and I really call this also an equipment failure problem. We're going to learn about why the equipment's not working and what we can do to fix it, and that's essentially what we're talking about tonight. So, what is an erection? An erection is the ability to achieve and maintain an erection firm enough to have sexual intercourse. And so how common is erectile dysfunction? Well, it's pretty common. About 1 in 5 men 20 years or older experience ED in their lifetime, and that's absolutely true. We see patients as young as even 18 years old who have problems with erectile dysfunction, and that's because there's a wide variety of causes of ED. And more than half of men over 40 will have some degree of erectile dysfunction sometime in their life. So how does the erectile function, how does it work? So this is the cross-section of your penis. The where it fills up, this is the corporal body. It's this honeycomb material here and here. The arteries go inside the cavernosa, the honeycomb. And the way it works is you get a signal from your brain when you get excited, and it goes down through your nervous system. You can think of that like the electrical circuit. It sends the signal to the penis, and the signal will dilate the arteries, the penile artery, and increases blood flow into the penis. And while it's increasing blood flow, that pressure in the penis will collapse the veins to keep the blood from leaking out. And that's how you get an erection. And when you're done, the signal stops from the brain, the blood flow decreases, the veins open back up, and then it becomes flaccid again. So what causes erectile dysfunction? Well, most of the time it has to do with vascular or blood flow causes, and that can be from a combination of diabetes, which affects blood flow. It can be peripheral vascular disease, which affects all arteries and throughout the body. It can also be caused from prior pelvic surgery, from having prostate cancer surgery or colon surgery. It can be caused from other neurologic problems like pelvic trauma, anything that could injure that wiring system down to the penis can cause problems getting an erection. So like we talked about before, there's a lot of men have diabetes, 15.3 million, it says on this slide. And again, that's really one of the #1 causes of erectile dysfunction in the United States. So one of the other things we're always concerned about when a patient comes in with erectile dysfunction is, do they have some underlying medical diseases that they don't know about and we don't know about? And why is that important? And that's because a lot of times erectile dysfunction is the first symptom in a person who has coronary artery disease. And the reason for that, as we go to this slide, has to do with the size of the penile artery. Now, this obviously is magnified, but the penile artery is 1 to 2 millimeters. And right next to it, the coronary arteries are about twice the size, 4 millimeters. And so when disease is affecting all arteries throughout the body, obviously the smaller arteries are going to be affected first, and that would be the penile artery. So when a person comes in who is in that age range where we need to also be concerned about coronary artery disease, and they start first complaining about, oh, I'm not getting good erections, well, we have to think in the back of our mind, hey, have they had their cholesterol checked? When's the last time they've been to the primary care doctor? Get their blood pressure checked. How's their blood pressure? What medicines are on? All these things go into the thought process when we're dealing initially with erectile dysfunction. Another cause, or lower on the totem pole, but it's still a little bit of a cause, is low testosterone. And that's, in the past decade or so, low T has really been advertised a lot. But in reality, low T, when your testosterone is low, you're going to lose your sex drive, not necessarily lose your erections. But it can be a factor if your testosterone level is super low. And so in patients who come in with complaining about ED, we always do check their testosterone level, because we do want to see sort of where they lie. Because if it is low, and low typically being below 350, we might consider replacing it, especially if they're having the other symptoms of low testosterone, which can be, besides low sex drive, they can be losing muscle, they can be gaining weight. So that's why we check that. And this lists some of the more common, it's sort of associated with patients who have obesity, diabetes, high blood pressure. The same thing that causes erectile dysfunction. So they're all sort of related. So what it was, this slide just goes over some of the options for low testosterone if you are diagnosed with it. There's testosterone gels. They've been out for many years now. It's topical. You just rub it on your shoulder when you get out of the shower. You do it every day. There's patches, which I think recently were taken off the market. They just stopped making them. And now there's oral medications, which is the newest way of replacing testosterone. It's a pill. You take it 2 to 3 times a day. And the old tried and true way is injection therapy, which we actually teach the patients how to do themselves. You give yourself an injection typically twice a month to replace the testosterone. So those are all different ways you can do this. Now, how does, why do you get erectile dysfunction when you have prostate cancer surgery? And again, it's not a blood flow issue unless you already have underlying vascular disease, but for most men, it has to do with the nerves. And as you can see here, the nerves right here, these little pale yellow are the nerves that go toward the prostate. But if you follow the nerves further down, it doesn't show it, but further down going this way is the penis. And so the nerves to the penis travel past the prostate. And when we remove the prostate, obviously, we have to separate some nerves from the prostate, and we do what's called a nerve sparing procedure. So we still save the nerves, but we're moving them out of the way. And these nerves are tiny. And just touching the nerve will paralyze the nerve for a long period of time, sometimes up to a year. And so that's what's causing the erectile dysfunction in patients who've had prostate cancer surgery, and also in patients who have colon cancer, colon surgery that's way down there near the prostate. They too can be moving the nerves and touching the nerves, and that affects their ability to get an erection. So This slide again talks about the incidence of erectile dysfunction after a prostate cancer surgery, and it can affect anywhere. It's a big range, 25 to 75% of men. And again, that a lot of that has to do with your underlying disease, how your erections were actually before your prostate cancer surgery. So if you have great erections, you don't have to take any Viagra, Cialis. The likelihood of you maintaining your erections after surgery is much higher than the person who is already having some erectile dysfunction prior to surgery. Another cause of erectile dysfunction, which we see, is Peyronie's disease. So Peyronie's disease is basically scar tissue developing inside the penis, and it's right here, and it occurs right on top of the corporal body and what's called the tunica albuginea, which is this thick sheath that goes around the erectile bodies. And be honest, honestly, most of the time we don't really know what causes it. Probably 70% of the time, it's really unknown. The theory is it's micro trauma to the penis over time, just from having sexual activity. No serious injury ever occurs. And then one day, patient starts having some pain when they get an erection. And then a few months later, they feel a knot. And then the next thing you know, there's curvature. And the curvature always occurs toward the plaque. That's because the penis has to stretch out. And if one side's being tethered, then the penis is going to curve toward the side that's being tethered. Well, fortunately now, in the past 5-6 years, we now have an FDA-approved treatment for Peyronie's disease, a medical treatment, because prior to that, everything was off-label to treat Peyronie's disease. And I'll just mention it briefly. It's called Xiaflex, and you just have to inject the medication into the plaque. It's done through a cycle, up to what we call 4 cycles, and there's 2 injections each, and it actually does help when you have curvature. So that's a great thing, because the only other thing we can do after that, if that doesn't work, is a surgical procedure to fix it. So what are the ways we can now? So those were the causes of the equipment failure. What is the treatments to help fix this problem? There is basically a whole menu of options out here, and they range anywhere from just as simple as a pill, which is Viagra, Cialis, all the way up to a surgical procedure, which are penile implants. The oral medicines initially came out in the late 90s. Obviously, the first one was Viagra, and then Cialis, and then they had Levitra, and now one of the newer ones is called Stendra. Most patients now in the year 2024 have probably tried an oral medication. There's just been billions of prescriptions written for it. And they all essentially work the same way. They dilate the penile artery, and it increases blood flow to the penis. If that fails, then we can move on to injection therapy. Injection therapy has also been around for a long time. It predates the oral medicines. It probably started in the 80s. And most of the time, it's a combination of 3 agents that you inject directly into the penis. So it's bypassing the whole nervous system part. You don't have to worry about a signal getting down to your penis. And it works real quickly, usually within 5 minutes of the injection. Vacuum erection devices are also been around for a long time. Not one of my favorite things that I recommend for patients, but it is an option. The reason I don't like them so much is the way they work is you're basically using suction to draw blood down into the penis, but to maintain the erection, you have to put a really tight rubber band at the base of the penis, and it's pretty uncomfortable. Urethral suppositories, that's actually came out prior to Viagra back in the mid-90s, and it's called Muse. It was popular for about 1 year, then Viagra came out, and then it disappeared off the market. Well, here it is, 20 plus years later, everyone's tried Viagra, so now we're back to trying the urethral suppositories again, and they work so-so. That's about all I can say. And then the final thing, obviously, is the penile implant, which is a surgical way of correcting the erections, really once and for all, without having to worry about it again. So the oral medications, again, like I said, they all work the same way. They're called PD-5 inhibitors. And again, it just increases blood flow to the penis. And, if you've never taken them and you don't have that many serious underlying medical problems like long-term diabetes, they work well. They really do. And that's what almost everyone starts with, because it's simple. You take a pill. Usually you do it an hour before you have sexual activity and you get an erection. So it's a simple way of treating ED. The only time you really cannot take one is if you're on nitroglycerin or a form of nitroglycerin. Those interact and can make your blood pressure drop significantly and cause some cardiac issues. So that's the only time you cannot really take it. If you're on Flomax, it's recommended you separate the oral agent, the Viagra, Cialis, 4 hours apart. The injection therapy, like I had mentioned before, it works very quickly. You inject it right into the corporal body. Works with you typically within 5 minutes. Some of the risks, though, is there are some risks with it, and one of the biggest ones we worry about is a prolonged erection. That's called priapism. You don't want that to happen because one, if it doesn't go down, you have to go to the emergency room to get it reversed, and priapism puts you at risk for having worsening erectile dysfunction. The other thing that can cause more common things are just pain at the injection site. Long-term use of it can cause scar tissue, which is similar to the Peyronie's disease we were talking about before. The vacuum erection device, like I said, it's just a way of drawing blood down into the penis. They're over the counter now. I'm not a big fan of it because of the tight rubber band you have to use at the base. It's uncomfortable and it really can inhibit ejaculation. The urethral suppository, once again, the way it works basically is you urinate first to lubricate the inside of the penis. You put the device down, you release the little pellet. It's probably about, I don't know, 3 millimeters. Then you rub your penis to get it absorbed. It burns some. It takes 20 to 30 minutes before you start seeing any effect. It also has to be refrigerated, and it's very expensive. And then lastly, is the penile implant. So a penile implant, obviously, it's a surgical device. It's all self-contained. It's all internal. It's filled up with saline. And after you get over the recovery, it works great. The satisfaction rate is 98%. Recovery, the whole process takes approximately, it's about an 8-week process. The surgery is typically outpatient. You're sore for a couple weeks. After about 3 or 4 weeks, you start practicing with the device. And after 6 or 8 weeks, you can have sexual activity. The 3-piece prosthesis, which was actually invented by AMS, which is part of Boston Scientific, almost 50 years ago. So it's been around for a very long time, well before the oral agents, well before vacuum erection devices. It was actually the initial treatment for erectile dysfunction back in the 70s. This device, called the AMS 700, is actually coated with antibiotics on the surface, which really helps prevent infections, not only in the short term, but also in the long term from the surgery. So how does it work? How does the penile implant work? So this is a video, and it's going to start in just a second, and it shows you how a person would inflate a penile implant. So we'll go ahead and watch this. All right, so this would be a patient who has an implant in. It's flaccid. You can see the pump sits at the bottom of the scrotum. That's where we try to always place it, sort of in between the testicles. And through the skin, you squeeze the pump and it inflates it. Now, it stays inflated as long as you want. When you're done having sexual activity, then there's a button on top. You squeeze it, you hold it for 4 seconds, and then it'll start deflating on its own. You actually can even squeeze your penis to help speed along the deflation process. And that's all it is. It's a simple thing, and it works very well. All right, let's move on. All right, so how does it work? So the procedure takes about an hour. There's 2 ways to put penile implants in. One is just below the base of the penis. The other is in the scrotum. I do them both ways. I've done hundreds of them both ways. Most of the time, I typically do it through the base of the penis, mainly because there seems to be less swelling if you don't have to go through the scrotum. But either way is fine. And you can return to really normal activity after a few weeks, just because it is sore down there when this type of surgery. And then, like it says, 4 to 6 weeks before you can actually have sexual activity. So there is a learning process, and that usually starts around week 3 on how practicing and inflating it and deflating it. There are some risks with penile implants. Obviously, you have to be medically cleared. It does require general anesthesia to put a penile implant in. You won't be able to have, let's say you put the device in, 6 months later, you're like, hey, Dr. Kaplan, I don't like this thing, take it out. Well, yeah, it's no problem to take it out. It's another surgery, but once we take it out, there's no getting any more spontaneous or natural erections again. You're pretty much done. So once you go with the penile implant, that's how you get your erection from that point on. There is a risk of mechanical failure. It's pretty low. Most of these implants will last on average about 10 to 12 years. But since they are mechanical, if they ever break or something goes wrong with it, it does require another surgery to repair or replace it. And then another risk, which honestly is very low because of the antibiotic coating, is infection. And infection doesn't necessarily occur like a week after surgery. We're concerned about infection anytime. It could be 2 years later. And so if that ever happens, you just give us a call back. We initially always try to start treating it with some antibiotics right away. If that didn't work, then that's one of the times we'd have to take it out, wait a period of time, and then put another one back in. But overall, the infection rate is about 1 to 0.2% to 2% at the most. This is a good slide. It talks about, everyone wants to know about this. What does it cost? Does insurance cover it? Medicare, it is a covered surgical procedure under Medicare. It always has been. If you have a supplemental, that's the only question. Usually the supplemental will cover it because the Medicare is covering it. So yeah, so the answer to the question is, yeah, Medicare does cover it. Then the bigger question is, what if you have a commercial payer? Years ago, I would say 100% of the time they covered it. Now it really depends on the fine print and your company, whether they want to cover penile implants. But even with that said, it still seems to be covered, I'd say 80+% of the time for commercial payers. If it were to be denied, then there's an appeal process we can go through that we take care of to see if we can't still get it covered. But there's really no out-of-pocket expense initially. We don't even schedule the surgery until it's approved by the insurance company. Like we talked about before, the satisfaction rate is very high, greater than 95%. It is covered by most insurances. It lasts at least, for the average 10 years. Nobody will know you even have it in when it's deflated. It looks, no one would ever know. And then, one thing I didn't mention, it does take a couple of minutes to pump it up. It didn't really show that well on the little animation. We call that the foreplay. It takes honestly about 2 minutes to pump the thing up. And that's just realistic. Let's see here. Oh, one last slide we want to talk about is these other treatments that we consider investigational as urologists. These are alternative treatments. In other words, they're not approved, they're not FDA approved, and they're not really proven in the medical literature. They haven't been a proven therapy. And those include low intensity shockwave therapy, which has been around now for probably about 8 years. A lot of this stuff you'll hear about on the radio with these men's health clinics. Intracavernosal stem cell therapy and PRP, which is platelet-rich plasma. None of these are proven therapies. So typically urologists, you're the experts in this stuff. We don't recommend treatments that are not going to work or at least have any durability. And all this stuff is cash pay only. Insurance would not cover any of these options. And that's pretty much it. That's the end of the talk. Now we'll go into the question and answer session.
Thanks, Dr. Kaplan. If you don't mind, just leave that up on your screen for just a couple minutes while we go through these questions. If you are interested in setting up a one-on-one appointment with Dr. Kaplan, there's contact information on the screen for you. You can jot that down or take a picture with your phone. And as a reminder, there are anonymous chat box. Please drop your questions in there and we'll pitch them over to Dr. Kaplan to answer. So Dr. Kaplan, can you talk a little bit about the connection between high blood pressure and ED? I know you touched on it briefly, but maybe elaborate a little bit more.
So probably the number one connection isn't so much the high blood pressure, it's the medications you're on. There's a whole slew of blood pressure medications, and almost always one of the side effects, no matter which one it is erectile dysfunction. And that's really the underlying problem. It's the drugs that cause it, and there's no way you can get off the drugs. And almost, sometimes your medical doctors can switch you from one to another, may have a little bit less, but all of them, especially beta blockers, seem to have some ED effects. High blood pressure also does cause a little bit of vascular disease, which can narrow the arteries, but really it's the medications that do that.
Thank you. And you just talked about shockwave therapy, but could you explain a little bit more about what that is and why it's not effective for ED?
So shockwave therapy initially it's the same kind of technology that we use for kidney stones to break up kidney stones with sound waves. And the whole theory of it is using sound waves to you basically just you're aiming the device. It's like a little probe that goes over the penis and the perineum, and you're sending shock waves into this area with the hope of generating new blood vessel growth. Well, we've just never seen that really happen. We've tried it before. It just doesn't last. I mean, and we're not sure that it's even doing anything versus what we call a placebo effect. So it's just like I said, there's no data that shows that they're long-term data. Long-term data meaning this thing's going to last a year, 2 years, 3 years, or longer. So that's the problem. So that's how it works, or at least that's in theory. That's how it's supposed to work: is generate new blood vessel growth.
And what are the long-term risks or effects of injection therapy?
So the number one long term would be the forming the scar tissue inside the penis. It's called fibrosis. Um, and so we always recommend to alternate both sides of the penis. But even with that, when I say long term, you've been using it for more than a year to 2 years. That's when we can start seeing this. It's almost like a plaque. It's just hard tissue, and then you get Peyronie's disease. It starts curving toward the scar again. So that's the biggest long term. Um, Other than that, and obviously the prolonged erection, that's always a risk, but that's more of a short-term thing. But the long term is the scarring.
Is there potential for a better outcome by combining ED medications? That's a good question that I don't think we've gotten before.
So that's that's a good question. So some patients will alternate, some, they will try a Viagra, and then the next day they're going to do Cialis. I think that helps, but it's not recommended to take both on the same day, because it's really what's all you're doing is you're not getting a better erection. You're just getting more side effects and putting your blood pressure at risk of dropping to a scary low level. So it's not recommended to do that. Because these medicines, I don't know if you know that they initially were, at least Viagra was initially started out as a blood pressure medication. And during the studies for the blood pressure trials, they noticed everybody was getting erections, and they realized, hey, this stuff actually works better for ED than it does for blood pressure. So just be aware of that. It can drop your blood pressure.
All right. I think this might be the number one question that we get. Can the penile implant increase size?
That's a good question. And penile implant, unfortunately, does not increase the size. So they're all customizable. We measure you at the time of surgery. I look at it like a shoe. We always a way to measure the internal measurement, the external measurement. We have all the sizes there during the surgery, and we just put in the one that fits. So when a natural erection actually is always seems to be a little bit longer than a one with an implant. And part of the reason for that is the implant doesn't go all the way to the tip of the penis. If it did that, it would eventually erode and pop out. So that's no good. It sits back, halfway up the head of the penis, and that's where we leave them. But over time, they're like tissue expanders. They stretch the tissue out, and you actually will gain some length back over after about a year. You can get up to an inch more in length just from stretching the tissue out. So the answer is it will not make it bigger. So just be aware of that. But over the course of a year, it does stretch out some.
Can you speak to the natural male enhancement, both pills and liquids that are sold in health food stores?
That's
Maybe
a
what
good
are the
question.
ones we
I got that question again today from patients. Like, so they were asking, what can I take to help boost my testosterone? That's a supplement, and there just aren't any. There's no, and if they're saying that, the problem with supplements is they're not FDA regulated. That means they can put whatever they want on the label, and you don't know what you're getting. They can say it's got X in it, it could have Y in it. It's not tested. It doesn't have to be, certified or anything. So the answer is no. There's no supplement out there that will increase your testosterone or anything like that. And when you take these pills from the gas stations to help your erections, usually it's got some type of Viagra in it,
So
which is,
kind of tied to that. I'm sorry, go ahead, Dr.
yeah,
Kaplan.
no, go ahead. No, that was it.
Okay. So how important is diet for ED? Are there foods to avoid or
Sure.
foods?
So diet, again, that goes along with the underlying medical diseases. It's called the metabolic syndrome. So you obviously a healthy diet's not only good for the heart, it's good for the penis. Anything that's, if you want to keep your cholesterol down, you want to keep your blood pressure down. obesity, high blood pressure, smoking. If your waist size is over 40 inches, that puts you at risk for what they call the metabolic syndrome. That's what the medical doctors call it. Basically, all that causes cardiovascular disease, but it also causes erectile dysfunction too. So just eat, that's a healthy diet's important for all the whole body, not just the heart or the lung. It's for everything.
That's not the answer we want to hear, Dr. Kaplan.
I know that's no fun. Mhm.
All right. How does alcohol consumption have any impact on ED?
So, I don't really know the exact mechanism, but we do know, obviously, if you drink a lot of alcohol, it can inhibit your ability to get a good erection or maintain it. And really, I think it has to do with the signal. You're getting that signal through what I said, the circuit, the electrical circuit. It's inhibiting it some. So you're not getting the signal down to the penis when you have high alcohol consumption. That's what happens.
I know you mentioned supplements generally are not something you recommend. This person is asking specifically about nitric oxide supplements.
Yeah, so none of that's going to work either. It's just all going to get broken down in the stomach and metal. It's not even going to. It's just not going to get to where it needs to go. That's the problem. Yeah.
So if Viagra and Cialis are not effective for me, what's the next step? Is implants the way to go?
So typically, what most urologists, and especially the ones in my group who specialize in erectile dysfunction, we basically, most of the patients we see, they've tried the oral agents, and then I usually recommend at least trying injection therapy next if a person's willing to give themselves a shot with a needle. It's a tiny little needle. It's an insulin needle. Honestly, we always do the first dose in the office. I do it for the patient, and it's a lot. They think it's gonna be horrible, but it's almost painless. It's such a tiny little needle. And if that works for them, that's the way you go. If some patients who just cannot do it, give themselves a shot in the penis, then the next thing I recommend is a penile implant if you want to skip the injections.
And would an implant still work if I have Peyronie's disease?
Yeah, so it will work. And actually, that's a good question because a penile implant a lot of times is used to correct the Peyronie's disease. We actually use the implant to straighten out the penis. It's done at the same time. So patients who come in who have erectile dysfunction, who have Peyronie's disease, the recommended treatment is to not do Xiaflex, but to do a penile implant because there's ways during the surgery we can correct the curvature at the same time. So it's one treatment takes care of both problems.
If I get surgery, will I still be able to climax after?
That's a good question. Yes, it does not affect your ability to have an orgasm at all. That's all controlled by what we call part of the central nervous system. That's unaffected. Won't affect that at all. Doesn't affect urination. It doesn't affect ejaculation. None of that.
Love this one. Is there an age limit for erections?
Is there an age limit for erection? So theoretically, no. I mean, a man should be able to get an erection throughout his entire life, as long as everything's intact. In other words, he hasn't had prostate cancer surgery, or that's that, or colon cancer surgery. Yeah, he should be able to get it all the way to the very end.
How about taking low doses of ED medications daily? Do you recommend this?
So yes. So I do recommend it in some patients. I find that we also know that low dose like Cialis can be used. It's helpful for patients who have urinary symptoms or BPH. And I think it works probably a little bit better for that. It works better for the prostate than it necessarily does for the penis, but it does, so a lot of patients who have both problems and they've never been on anything, yes, I will give them low dose tadalafil to treat both problems at once. But if their bigger problem is really more of just erectile dysfunction, I think the higher dose works better for that.
Has there ever been a time where the three-piece implant has caused an allergic reaction? It's a good question.
Never. I mean, you can probably agree with that, Amanda. I don't know if any. It's silicone. I've never seen any reaction. No allergic reactions. There's just, from penile implants. I've never ever seen it.
Yeah, and the implant is coated in rifampin and minocycline. So in the rare case that we've occasionally will see an antibiotic allergy, And in those cases, Dr. Kaplan, you might choose to use an uncoated device in that case.
Sure. But that's those, most people, those are such, they're not really use those antibiotics very often orally or IV in the normal situation. So patients, it's just so rare. It's so
Very
rare.
rare. Yeah. Okay, so how many years will an implant work?
So yeah, like I said before, on average, they're good for 10 years. I've seen them last, a lifetime. It really depends on how much they're getting used. It's like anything else. It's like, the more you use it, it could eventually wear out. So, but for the average person, like I said, they're good for 10 to 12 years. If you're only using the device periodically, it's probably gonna last forever.
Are there medications, specifically heart medications, that I cannot use with my ED meds?
Yeah, so like I said, the that was the main one is just nitroglycerin based medications for, when you're having chest pain. That's the only one. Anything that has nitroglycerin in it, you cannot take. It's contraindicated to take um a PD-5 inhibitor, whether it's Viagra, Cialis, or any of them, if you're on that. And the real, even if you're carrying it around, the problem is you take a Cialis, it stays in your system for a while, and then you get chest pain, you take a nitroglycerin, there's a problem. Then you can have a potentially extremely low blood pressure, and that can cause some heart problems. Other than that, no, you can pretty much, it's safe for all the other stuff.
Is there any correlation between enlarged prostate and ED?
Not really. It just happens. It's an age-related disease, both of them. So we see them hand in hand a lot of times with men. But one doesn't necessarily, just because you have an enlarged prostate, it's just not going to cause erectile dysfunction. They just sort of, it's just, like I said, age-related. That's just part of it. Or two different diseases, but they happen as you get older, just like anything else.
Very good. Um, is implant surgery the best option for after green light? Maybe you could speak a little bit about what green light is, and then
So green light is a treatment for an enlarged prostate, BPH. So you can do a penile implant on anyone who's had BPH procedures after the procedure. The real question is, if you have a penile implant in already, what procedures are safe to do to treat prostate? And so there are some BPH procedures that you cannot have if you have a penile implant in. Green light is one that's fine. Any laser procedure is fine to have if you have a penile implant in place. You can have what's called a TURP, transurethral resection of the prostate. That's completely fine. Um, the ones that become an issue are the ones like the minimally invasive ones, like um, Urolift, because you're passing a needle through the prostate. I guess there's theoretically a chance it could hit the penile implant potentially, and that would be a problem. That would damage the implant, and then it would have to be replaced. And the other one is called Optilume BPH, which is one where you stretch it out, and they also say you cannot have a penile implant in. So, but if you already like I said, if you can always have any BPH surgery before a penile implant is put in. Once it's in, you can have a Urolift, you have that in, and then you want to have a penile implant, that's fine. You just can't have it the other way around.
very good. Um, so during penile implant surgery, what mechanism do you use to determine length and girth?
So that's a great question. There's a measuring tool that we use. It's called the furlough, and the furlough measures. It's got marks on it, centimeter marks, and we just measure it, and that's what we put in. They come, like I said, they come in a whole bunch of sizes. Amanda brings all the sizes, and we just put in the one that fits. So there's an instrument that we use for that. So
Okay.
a lot of what you see on the outside is just part of the length of the penis. There's a significant portion that's internal that you don't even know about.
Excellent. Well, Dr. Kaplan, we've had a really engaged group tonight and lots of good questions.
All
So
right,
I think
those are
we'll wrap
good.
there. What we'll do after this, everyone will receive an email with a link to the recording so you can watch again if there's anything that you missed or you want to hear again. And there will also be some details on how you can contact Dr. Kaplan if you want to have a follow-up discussion with him. Thank you all for spending your evening with
Thank
us.
you guys. Thanks a lot. I appreciate it.
Thank you so
You have
much,
a good
Dr.
evening.
Kaplan. We'll see you next time. Take
All
care.
right. Bye-bye. Have a good
Bye.
night.